A typical jitter analysis study suggests that recording from 20 different end plate pairs. How many abnormal recordings are allowed in a normal muscle? Or what is the number of outliers that you would accept?
When we looked at the normal material, when we collected that long ago, we saw that the distribution is pretty Gaussian, and therefore we decided more or less to use the 95% cut-off limits. That means that 5% can be abnormal. That means since we tried to get 20 recordings, we allow one to be abnormal. Any degree of abnormality, even with blocking. If we have two abnormal increased jitter and maybe one is blocking, that is a borderline finding. And if we have three, it is definitely abnormal. Why do we have so-called outliers? Well, first of all, it's a statistical phenomenon that we have this Gaussian distribution. But the other thing is also that with wear and tear, with age and all these things, we may have some abnormalities. But the experience is that it is not more than 1 out of 20 in the way we have defined the reference material. And that is different for different muscles.
Well, if we try to translate this into the situation with stimulation single fiber EMG, it must be realized that in the volitional jitter study, 20 recordings include 40 end plates. So we should actually try to collect 40 values in stimulation single fiber EMG. We often get a little less than this, maybe 30, but in our lab we are rarely satisfied before we get 60. So we say that our limit of normality would be 4 end plates out of 40. 3 out of 30 maybe. But you know, here we are actually, we would have to consider not only simple statistics but also probability calculations to get down to the similar normative value as in the volitional study. But to keep on the safe side, we said 4 out of 40 or more is definitely abnormal.
No matter what criterion of normality or abnormality we use, we have to interpret this study, and that interpretation is based on all of the information available. And you want to avoid the possibility of making an erroneous diagnosis, and therefore I would not make a diagnosis of any disease based on only minimal abnormalities, particularly if the patient has more than just minimal symptoms.
What we actually do when we have obtained such borderline results is to ask the patient to come again. And this is practically always, it is a routine. The patient comes after a few weeks again, and sometimes the clinical picture is more convincing, and very often the sfemg is more abnormal.
And of course you can always do another muscle that's more likely to be abnormal, based on the clinical findings.
The other way to express abnormality is to take the mean value of all the 20 recordings in volitional or all the 30 or 40 in stimulation sfemg. The MCD is, statistically speaking, often little more diagnostic than the outliers. And when we calculate the MCD, we should not include those pairs that have a jitter above 150 microseconds. They can actually be very, very high, and then they also contain blocking, which means a very irregular innervation rate for that particular fiber, which increases the jitter for certain reasons. So only jitter values below 150 should be included in the final calculation of the mean MCD for the 20 recordings.
We actually do the same. We assign, when we have a very large jitter value with inner blocking potential, then we translate this into 50 microseconds MCD. And using this way of calculation, we actually found that our result is slightly different from yours, Erik. The MCD in our hands, mean MCD of the whole study in our hands, is slightly less sensitive than the outlier criterion. But this is after correction, as you say.
I thought so too, also from the beginning, when and often in medicine we look at outliers. We look at spikes in the EEG. We don't take the mean frequency. We look at café au lait spots in the patients with
Von Recklinghausen's neurofibromatosis.
Neurofibromatosis, and so on. We look at outliers. We don't take the mean color on the skin, for example. And therefore we thought that outliers was really a good thing. But when looking at the larger material, to my surprise, the MCD was a little more abnormal in the way it was defined. And I think, Don, your experience is what?
Yes, my experience is the same. There is a very slight greater frequency of abnormality in the mean MCD value than there is in the number of outliers in a large material, but it's very small, very little difference. I think either one of them is an acceptable criterion. And again, if you're going to be relying on such minimal criteria of abnormality, then it's wise not to make a judgment, not to make a diagnosis based on such minimal findings, but to either repeat the study by having the patient come back or check another muscle, get more data.
One nice thing with outliers is that you really do not need to have 20 recordings to establish that the study is abnormal. If your first 5 recordings were abnormal, then the study is going to be abnormal, whatever mean MCD you finally got.
Well, I must also say that the difference between the diagnostic value of mean MCD as compared to the number of outliers is very small. And I must also agree with Don, what we do is really to add another muscle immediately. And even only when this second muscle is normal, we ask the patient to come again.